Hi, Lisa White with IVF Manifesting a Miracle. I'm here with our friend, Dr. Greene, for another clinical conversation today. How are you doing, Dr. Greene?
I'm doing great, and I even have audio visuals today.
Awesome.
We're talking about a specific article from last week.
Yes, we're kicking off December 2021 with a recent article that you read about in the, where was that? The New England Journal, right?
Journal of Medicine, exactly. It's kind of like the New York Times for healthcare providers. It's really considered one of the major general journals to reach all doctors and all specialties instead of targeting one specific specialty. So when something hits the New England Journal that's related to the field of fertility, it gets a lot more attention, both within the reproductive community as well as within the medical community and the media in general.
Okay. Well, one thing I appreciate about you is that you're the data guy, you're the data science driven guy, and here to shed light on the findings of this article. The topic that we're going to talk about is genetic testing versus no genetic testing in patients with good prognosis.
Exactly. And let's start by just talking about the study, because one of my greatest concerns is that the study design is flawed. It does show what the media is talking about, but it does it because there's a very significant flaw in the design of the study. They're looking at the simple outcome of live birth rate. You know, is one path more likely to create a live birth than the other? And, you know, they're not really factoring in all the bumps along the way. How many transfers might it take till you achieve a live birth, which is both cost and money? How many miscarriages might you have? How many more twins would you have with one pathway versus another? None of these things were factored in. And it was literally, instead of a study trying to design to show if one was better than the other, it's designed as what's called a non-inferiority study. They're trying to show one isn't worse than the other instead of asking a question, which one is better? Because better is different for different people. So let's talk about the study first, and then we could talk about the flaws and where I think some of the design issues came up in the way it was designed. This study was done in China, where it's much easier to randomize people. And that's an important part because, you know, in healthcare, it's often considered the ideal is to have a randomized study where you can randomly take a group of people, and without asking you, what do you prefer? We just do a lottery and say, you're going to do this and you're going to do that. And as we know, most of us like to have it our way. So most people don't want to be randomized. So it's very difficult to do a study like that in the United States. But this was a large study where they randomized over 1,100 people into doing either, embryo transfer with untested embryos, or they were doing embryo testing with genetically tested embryos. And what happens is that the study was randomly assigned so that people were in one versus the other. And it's really kind of interesting because, you know, each category was considered to be up to 3 transfers. And they weren't saying who's going to get pregnant quicker, who's going to have the lowest risk of miscarriage, but is there going to be a difference in multiple births after the total of 3 transfers if you go one way or the other? And, you know, on the surface, that sounds like a reasonable comparison. But when you look at the study design, they only agreed to test a total of 3 embryos in the people that were getting embryo testing. So they found that people in both arms of the study had up to 8 embryos available that got frozen on average, but they only tested 3 in the people that were doing genetic testing. And so what they found is that the majority of people had at least 1 abnormal embryo. So most of the people in the genetic testing arm didn't even get the opportunity to have 3 transfers. They only got 1 or 2. The other thing that they found is that people that were doing untested embryos were often putting in more than 1 embryo at a time in order to boost their odds.
Oh.
And so, the study concluded that the chance of a live birth after a total of 3 transfers was equal between both arms of the study, but it was very misleading because, if you look at the actual numbers, for instance, only 5 patients that were in the genetic testing arm had 3 embryos that were genetically healthy. So most people didn't even get more than 2 tries in that arm of the study. So it was very biased against that to begin with. And the reality is, for instance, if you're in the United States, if you have, 8 embryos, most people would test 8 embryos. You don't just say, I'm only going to test 3.
Right.
The other thing that they found is that the miscarriage rate was dramatically lower in the people that had the embryo testing. So even though the pregnancy rates were, often very good in these good prognosis patients putting in untested embryos, they often had a miscarriage, which created both further time delay. But in the United States, it would also be additional cost because people here often have to pay for each embryo transfer. So if you have to do 2 or 3 transfers, it actually tends to be more costly, both time-wise as well as financially, if you have to do multiple transfers.
And might I add, emotional cost.
Exactly. The other thing is there were a much higher incidence of twins and even a couple of triplets in the untested group because people were putting in multiple embryos instead of putting in one at a time. There was also and this was, I think, the most interesting part, but it didn't get any media play. There was a higher incidence of birth defects in people doing untested embryos, which is interesting because a lot of people worry that doing genetic testing can damage an embryo, but it showed that there were more birth defects in the arm of the study where people were putting in untested embryos than in the arm of the study where people were doing genetic screening. So even though this is being related in the media as a big success and that people don't need to do genetic testing, the asterisk should be that's only if you're willing to do more genetic, or more embryo transfers, accept a higher risk of miscarriage, accept a higher risk of birth defects. And most people in the United States would prefer to, be able to at least participate in the decision making of yes, they do want testing, or no, they don't want testing, instead of having someone make a random generalization and say you should or shouldn't do it.
Yeah, I mean, optimizing your chances through this. And I think to help empower people through this, I don't know, why would people not want to know if it's a healthy embryo?
Besides just optimizing, it's also individualizing treatment plans.
Right.
I have some people that have had multiple miscarriages, and the thought of another pregnancy without having some degree of comfort that it's not going to be a miscarriage is a disaster for them, and other people are able to shrug off a miscarriage and say, you know what, I don't mind. I'd rather put in untested embryos. That should be their choice, not mine or anybody else's.
Yeah, I just, do you find most people who are hesitant to do genetic testing, or I guess you can't say most, it's not a general thing, but harming the embryo, that's really a low risk of harming an embryo by doing the surgery, as you say it, when you do.
Well, the reality is, and what you're referring to, and we talked about this previously as well, when you're doing genetic testing, you are essentially doing surgery on an embryo. And as we know, even a low-risk surgery can be very dangerous if it's not being done by a very well-trained and competent surgeon. So, this is why people need to feel comfortable with the available and published results of whatever center they're seeing. And if a center doesn't do a lot of genetic testing, it's probably best not to do genetic testing if that's the center you're going to.
Right.
But when you're going to a place that's doing multiple genetic tests every single day, and they've got excellent success rates, then you ought to believe that they know how to do things in a way that's safe and reasonable.
Yeah. And it's interesting just to break it down for people too. If, when I went through this process myself and I was told, send out the embryos for genetic testing, it's you're taking a small sample, right, of that DNA
Yeah,
from the embryo.
literally
I was thinking, oh, does my embryo get shipped off? And
yeah, no, literally you're removing between 2 and 5 cells from an embryo that's about 250 to 300 cells.
Mhm. Yeah, so that's what comes back, usually another, again, almost like a 2-week wait again to find out
Correct.
results of that. Yeah, so I just appreciate you breaking down that article, that it was kind of
Yeah.
misleading in a way.
Well, and you know, the way I like to explain it to people, and again, this is based on our internal results of many years in a row. A good prognosis patient, just like the ones in this study, same age range and everything, a
Yeah.
good prognosis patient putting in an untested embryo has roughly about a 50 to 55% chance of pregnancy per embryo. And they also have about a 10 to 15% risk of miscarriage once they're pregnant.
Mm.
Now, a genetically screened embryo has a 70 to 85% chance of pregnancy.
Mm.
And once they're pregnant, the risk of miscarriage at our center is below 5%. It's about
Wow.
3.8%.
Wow.
So, you know, again, it's actually giving people the actual data that relates to their prognosis at that particular center. And then you decide. Some people say, you know what, I'll put in 2 untested embryos and roll the dice. And other people say, you know what, I'd rather do 1 embryo and minimize the risk of miscarriage. And that should be an individual choice of each patient or patient couple. And they should be empowered to participate in that decision rather than have someone else try to interpret the data and say, this isn't even available to you, that you have to do this or you can't do that.
In this article, just can you define a little bit about good prognosis? Like, what does that look like in the article?
Yeah, basically, what this meant is they were deliberately screening patients, and I can read to you specifically, these were patients that were between 20 and 37 years of age.
Okay.
That had previously had a whole host of different underlying conditions ruled out. So
Okay.
these are the people that are typically between 20 and 37 that in the United States would meet the definition of unexplained infertility. There's no uterine factor, there's no male factor, there's not age-related changes, there's no history of previous miscarriages. So these are people that basically you've done all the testing and everything looks good.
Yeah. And at your facility, I know you strongly encourage individuals to do genetic testing, correct?
Well, again, we actually use the data and we let the data speak for itself. I think one of the things we all have to always be aware of is our own personal bias. You know, my concern is that this study seems to have been designed with a bias to show there was no difference in outcome. And so they deliberately, you know, designed it that way. My bias is, you know, yes, most of our patients get genetic testing, but a lot of people come to us because they see what our success rates are. They come to us because they know what we could offer. So we're not seeing a lot of the people that don't want genetic testing, but we give everybody the choice.
Yeah.
But admittedly, most of the people that come to us, for one reason or another, they're predisposed that they're either more likely to be not an ideal candidate, or they came to us specifically because genetic testing, or we just go over those numbers I just reviewed with you and they say, I want that, you know? So, you know, I wouldn't say that we encourage, I'd say that we do genetic testing on most of our patients. Part of that is the technology speaks for itself, and part of it is probably our patient population. We're not the only one in the area. And so a lot of people specifically select us for a reason.
And if, like, say a woman's 40 and over, like, do you take that into consideration with like age?
Absolutely.
Where you say, you know, I really strongly encourage or suggest,
Yeah, basically for anyone over 37, you know, they wouldn't have even qualified in this study.
Yeah.
Anybody that's over 37 is not considered an ideal candidate for untested embryos. That's exactly what I mean when I say that this study was designed to try to make it that, to only find the best of the best people.
Interesting.
And so, and one of the things people should always think about is before they decide they do or don't want to apply a study in their own situation, is they should ask, would I have even qualified to participate in that study?
Yeah.
If the answer is no, then the results don't apply to you.
Right. Interesting.
And that's why they deliberately didn't let anyone participate in the study if they were older than 37.
Can I ask you a question?
They didn't let anyone participate in the study if they had a low ovarian reserve.
Interesting. Yeah. May I ask a question that came in? Someone's going through a donor egg cycle.
Yeah.
And they had submitted a question to me. They're torn if they should do the genetic testing or not. It sounds like their donor is 25 years old. And something about her and her husband are different. The donor and her husband are different carriers, which, can you explain if, based on a young age of a donor?
Well, put it this way, if someone is a carrier of a preconception genetic condition, they wouldn't have qualified for this study. Because then you always offer that if you want, we could test for that particular condition. Now, when it comes to someone that's using an egg donor, again, you have to ask people, what is their goal? If someone wants to maximize their chance of success as quickly and efficiently as possible, sometimes it's best to do genetic testing, because, like for instance, say a donor produces 8 eggs. You could put in one the first time, which is what would have often happened in this study. And then if you don't get pregnant, put in 2 the second time if you're willing to accept twins. That often happened in this study, and put in 2 or even 3 the third time.
The embryos,
And that's what often happens when people are using from an egg donor. But if someone wants to maximize their chance of having one transfer, having a lowest risk of miscarriage, and having that one transfer be successful, and not having to just randomly keep trying embryos until they find the best embryo, then they might choose to do genetic testing, even if there's not a carrier issue. And again, that's an individual choice. But I'll give you another example. And I often have this discussion with couples that are using an egg donor. And this goes to something we've previously discussed. I always ask people, what does your ideal family look like to you?
Yeah.
Because if someone tells me they want to have at least 2 children from the same egg donor, then it's important that we know that there's at least one genetically healthy embryo left in the freezer for that pregnancy later on, because chances are you're not going to be able to find that same donor if you wanted to create a sibling. So if someone says, I want to have 2 kids and I've got 6 embryos, I always say you're better off to test them, use one now, and confirm that you have at least one to try for that second pregnancy later on.
Very good advice.
Yeah.
Thank you.
Individualization of counseling. I think that's more important than trying to say everybody should or nobody should.
Right. Well, you're very good at explaining this in an easy to understand way, and, helping educate us, inform us. And we did a talk again for anybody that's curious more about genetic testing. In my YouTube link, Lisa White, IVF Manifesting a Miracle, we did a talk on genetic testing as well as embryo grading. So there's lots of topics related to this, but PGTA testing, and so I appreciate you being here. People can find you at enhancingfertility.com.
Yep.
And you have lots of data you share and blog posts and great stuff. And I can be found at ivfmanifestingamiracle.com. Hang out on Instagram the most, but present on YouTube, where you can find a lot of these videos. So Dr. Greene, you're wonderful.
Stay happy, my friend. Happy holidays.
Yes, happy holidays, end of the year. Hopefully we got a couple more talks, I think, before the end of the year. So look forward to those.
Beautiful. Look forward to it.
Talk soon. Bye, everybody. Thank you.